Hello, I'd like to welcome everybody to our FoxP1 family chat today, and I'd like to introduce Jessie Mewshaw. Jessie is a speech language pathologist who works with a lot of autistic children and has experience with this PDA that we're going to hear about, Pathological Demand Avoidance. Jessie works in the North Carolina Chapel area, and she's going to tell you about where she is and how to contact her if you're interested. So Jessie, thank you for joining us, and please take it away.
Yes, thank you so much for having me. We're going to try to cover as much as we can in this hour. There is so much to talk about in this area of study, and this is one of my areas of special interest within my field. So I will get into it and dive into as much as I possibly can. But like Gail said, if you have any additional questions, please feel free to contact me. And I have lots of resources linked at the end as well, because I know that I am certainly not the only one talking about this stuff, and there's lots of great folks to follow for more information. I'm gonna move this little box out of my way so I won't be able to see most of you here. But if you have any questions along the way, I'll be keeping an eye on the chat here. Let me open that so I have that ready to go. Okay, cool. All right, so I'll tell you a little bit more about myself really quickly. My name is Jessie Mewshaw. I'm a pediatric speech language pathologist, and I've been working in this field for about 11 years. Prior to that time, I have been working with disabled children, teens, and adults for several years prior to becoming an SLP. And I worked in the US as well as abroad in South America and Australia before coming back and going to graduate school to become a speech language pathologist. I'm in private practice, and I predominantly serve autistic children and teens. And of course, a lot of my clientele also have co-occurring conditions such as, rare genetic syndromes, apraxia, dyspraxia. I have PDAers, of course, on my caseload. I have a lot of non-speakers as well. So if it falls in the field of autism, it's something I probably do. I not only do one-on-one therapy and group therapy services, but I also provide consultative services, caregiver coaching, and I do training and education as well. I tend to show up in the graduate classrooms down at UNC, which is here in Chapel Hill, quite a lot, and do a lot of guest lectures for the graduate students. I am quite passionate about the neurodiversity movement and fostering acceptance, inclusion, and advocating throughout my community for supports needed for neurodivergent kids and teens. I also am neurodivergent myself. I'm an ADHDer. My husband is an ADHDer. My children are ADHDers, genetics being what they are. So we have a big, fun, neurodivergent, sensory-seeking family, and it's always a party around the Mewshaws for sure. Okay, so really quickly, just want to chat about what neuroaffirming practice is. So most of you are probably familiar with that, but just in case you're not, neuroaffirming is also short for neurodiversity affirming. And what that means for me as a member of the neurodiversity movement is that I value neurodiversity and different ways of presenting and being and thinking. I operate from a strengths-based lens to help my clients to thrive. I don't ever think about fixing people because I don't think that brains need to be fixed. I use predominantly identity first language, such as the word autistic or the word ADHD, which signifies that the individual has a different way of being and thinking, that they don't need to be separated from themselves. The reason I use specifically the word autistic is because that is the identifier that is preferred by the majority of autistic adults. And so I default to that. However, the way that an individual prefers to refer to themselves is always up to them. So if somebody prefers to say on the spectrum or with autism, that is all kosher. Whatever you want to say is fine by me. I really value the lived experience of the populations I serve and find it to be really the most crucial piece of importance when thinking about how do we use this in clinical practice. So a lot of the information that you're going to hear about today not only comes from the research and my own clinical experiences, but comes from the lived experience specifically of PDAers, because we do have a robust community of PDA adults who are able to share their experiences with us, and we have a lot to learn from that. And at the end of this presentation, I have one of my my best friends who is a PDA adult provided a quote for me on their lived experience to kind of end us. And I just really love that. And I'm excited to get to it. I do a lot of pro bono education, but of course, always appreciate donations. I will have this linked at the end of the presentation as well. This is a link to my business Venmo. If you feel inclined, you are always welcome to make a donation for my talk today, but no pressure. Okay, participation. I am a chatty Kathy, and I could definitely sit up here and talk to you for this full hour, nonstop. I could go over the hour. That's no problem. But I really do like participation, and I love to hear feedback and questions and have you participate throughout if you want to do that. So if you have a question that pops up during this presentation, please feel free to unmute and interrupt me. I love an interruption. I have ADHD, so it's one of my love languages. You can also pop it in the chat, or if you're somebody who's just not as inclined to participate quite vocally in the middle of a presentation and you'd rather do that separately, feel free to jot it down. You can email me later. You can send me a DM on Instagram, whatever feels good to you. But I love to answer questions and have more of a dialogue around this topic. So participate in whatever way works for you. On that same note, screen on or off. It's totally fine by me, whatever's going to work for you. I imagine some of you might have children running around while you're trying to listen to this talk, and having the camera off might feel best. So no worries if that's what's best for you. All right, we're going to do a really quick overview of PDA. I imagine if you're attending this talk, you probably have some baseline understanding of what PDA is. So we're just going to kind of build that foundation really quickly here. PDA stands for Pathological Demand Avoidance, which is its original inception. That's what the PDA stood for. But later on, as PDA adults started talking about their lived experience, it was redefined as persistent drive for autonomy, which a lot of PDAers prefer. So I might use one or both like interchangeably. It was first suggested by Professor Elizabeth Newton Newson in the UK in the 1980s, which I think is important to mention because a lot of people are just now hearing about PDA for the first time, but it has actually been around for quite a while, since about my entire life. PDA has been around, but it is just now sort of entering the mainstream and being discussed more openly. And a lot of that has to do with the inception of social media and how easily we can get our hands on information now. There still is much controversy about what PDA is and what it isn't. We do not currently have a very firm, agreed upon consensus of what exactly it is and a firm definition of what it is. And I'm going to talk a little bit through some of the definitions, how I define it, and where do I derive that definition from. It's not currently diagnosable. Some people are under the impression that it is diagnosable in the UK, but it's still not. It's just better known, and so more providers are talking about it. It is sort of a descriptive profile, if you will, similar to in the SLP world, we might give a child a descriptor of being a Gestalt language processor, GLP. That's not a diagnosis, but we can still describe characteristics of an individual's profile using that language. That is the same with PDA. You might still see it in a report from a psychologist, from an SLP, from an OT, but it is not a diagnosis, more of a descriptor of what we're seeing and helps us understand where it might be coming from. PDA is not actually only for autistics. And I think that this is something that is lesser known. Very often, if you first learn about PDA, or if you Google PDA, one of the first things you're going to see is it's going to say PDA is a profile of autism. But when you look into the research on PDA, it actually shows that PDA is more highly correlated with ADHD, as well as emotional instability and antagonism, which are all ADHD characteristics. It's more highly correlated and associated with ADHD than with autism. Does that mean that we don't have autistic PDAers? Absolutely not. We have a lot of autistic PDAers, specifically ADHD PDAers, meaning that they are ADHD and autistic. We see that frequently in that profile, having that PDA profile. But I think it's important to mention this because we can have what's called allistic PDAers, non-autistic PDAers. And many ADHD folks, kids, teens, adults, also very much resonate with this information. And I think that's important to mention because it means that we need to be broadening our scope of who can be PDA and who can have access to the supports that we give to PDAers. So I always mention that when I talk about PDA. All right, so how do we currently define it? If you go to one site or another, you're going to see different definitions from every site that you go to. So what I'm going to do here is just kind of talk through what we pull from the PDA Society website, which is probably one of the most popular places people go to learn about PDA, but they've been talking about it for quite a long time. And this is the definition that they currently have on their website. I'm going to try to move these windows so I can see this a little bit better. I'm going to read through this a little bit, and then on the next slide, I'm going to talk about why this definition might be a little problematic or not quite refined enough for us, and then I'll kind of talk through how I define PDA. So from PDA website, clinical practice and much of the research literature describes PDA as a constellation of traits within autism, and then they do actually note at the bottom that there are non-autistic PDAers. But these are some of the core features of PDA as they outline it. Resists and avoids the ordinary demands of life, uses social strategies as part of the avoidance. And as you see that I've bolded certain words, the reason I've done that is because I'm going to come back to that. Appears sociable on the surface, but lacks depth of understanding. Experiences excessive mood swings and impulsivity. Has obsessive behavior, often focused on other people. And a lot of PDAers are described as having their special interest is around people, specifically peers, as opposed to maybe things, objects, movies, things like that. And then appears comfortable in role play and pretend play, sometimes to an extreme extent. And they have recently changed a little bit of their definition of PDA, noting that it is a spectrum, can present differently in different people. And I think they've added that because they've realized that this definition that they've had for quite a long time doesn't always really match a lot of the PDAers that folks are living with or treating, or folks who are experiencing PDA. And we're going to talk about why that is. One of the problems with this definition of PDA is that it really doesn't leave room for intersectional identities, such as being non-speaking, okay, or having whole body apraxia. So if we go back to what that definition said, we had things like using social strategies as a way of avoiding the everyday demands of life. With an individual who is, for example, experiencing full body apraxia, they're very unlikely to be able to do something like this, right? So we wouldn't be able to observe that skill. But does that mean that they're not experiencing what a PDA does? It's not necessarily true, because a lot of the definitions here have to do with observable behavior. Go ahead, Carl.
Hi, sorry, could you define whole body apraxia?
Okay, well, yes. I don't want to
Thanks.
get into, I do have a little bit more on this at the end. I have a comparison between PDA and whole body apraxia. When speech therapists talk about apraxia, they're very often referring to apraxia of speech, which is, to simplify it, a motor breakdown of getting the words from the brain to the mouth and then actually producing oral speech. But one can experience full body apraxia, in which initiation of body movements is challenging, or the brain sends a signal to the body of what to do, but the body does something different, either nothing at all, the opposite of what the message was, or maybe just going through a rote, overmyelinated motor skill that they've done many, many, many times before, which we sometimes call motor loops. And with non-speakers specifically, we are often seeing some form of whole body apraxia. This could be, like I said, this could be a whole different presentation. And I did suspect that a lot of you would also be interested in that, and which is why I wanted to make sure I talked about it and included it here. Does that give you at least a foundation of what whole body apraxia is?
Yeah, thank you. And I'll go off and do more Googling later. Thanks.
Okay, please. And then if you have questions, email me, because this is another special area of interest for me, is non-speakers and the brain body disconnect and whole body apraxia is another thing I really like to learn about and talk about. Okay,
Jess,
so go ahead.
are you supposed to be sharing your screen right now? Because you're not.
Me?
Yeah,
Yeah. Are you not seeing my screen?
no.
Have you not been seeing it this entire time?
No.
I am seeing it.
Oh, are
Okay.
you?
Yes.
Oh, okay. I'm not.
Is anybody else not seeing my screen?
I'm seeing it.
Okay.
So
Gail, I'm sorry. I don't know why you're not seeing it, but I hope everyone else
I'll
is.
figure it out.
Okay. As long as it's being recorded, I think that's the important piece. Okay. So, right. This definition really doesn't leave a lot of room for those intersectional identities, such as having a different way of communicating. Even if a child is a Gestalt language processor in the early stages of developing language, they also may not have the language to use these quote unquote social strategies to get out of demands. So it can be quite limiting. When we look at a definition like the one coming from PDA Society, it's really limiting our scope to low support needs, verbal autistic kids, which isn't broad enough. There are PDAers all across the spectrum, and there are PDAers who have intersectional identities and co-occurring conditions. So we do need, I think, a more broad definition of what this is. And again, it really does greatly depend on observable externalized behaviors, and that is not the only way that PDA shows up. So this is my definition, which I have developed with the help of lots of PDA friends and researchers, and really looking at the research and thinking through what I'm also seeing in my clients. So this is a much simpler definition, but this is what I'm currently using. This is a working definition. I very well might change this in a month or two, right? But I've been using this working definition for at least 6 months now. PDA is a pattern of behaviors marked by extreme avoidance of internal, external, and self-imposed demands likely rooted in anxiety. And I'm going to talk about all three of those things and why they are important to talk about for PDAers, because demand avoidance, avoiding demands, especially external demands, is quite normal. It's a normal people thing. It's a thing that human beings do, especially kids and teens. What really makes it PDA versus just your everyday demand avoidance that we would expect kids to do is that internal and self-imposed demand. So I'm going to get into some definitions of those. Okay. So what are demands? We throw around that word demand all the time, but what does that really mean? I think when most people think of a demand, they think about those external demands, like a teacher asking you to line up for lunch, or your parent asking you to put on your shoes, or grandma saying you need to put down your iPad now because we need to move on from YouTube and do something else, right? Those are the everyday external demands that so many people experience, and especially for kids and teens who don't have as much autonomy over their lives, it is natural and normal for them to resist some of those external demands. That this is quite human. This is quite, and a lot of times when I'm working with a family of a toddler, and the toddler, starts developing the word no, and they start to resist demands, I tell them, this is a toddler's job. Their job right now as a mammal is to develop a life outside of you for survival purposes. If they're always dependent on you and aren't ever fighting for their autonomy and figuring out how to survive on their own, they wouldn't survive out in the wild, right? It is very natural for us to start pushing and wanting control over ourselves, our environment, and what we choose to do with our bodies. That's all very normal. I like to see this in kids when they start resisting some demands, because it is a form of self-advocacy, right? There is, of course, an extreme version of this, which, starts becoming unhealthy and unsafe, but some level of it. And I think everyone's here is a parent, and we can all relate to this, right? Even if you remember back to your own childhood. Oh yeah. I never wanted to wear that green jumper, and I wasn't going to do it. You'd have to break my arm to get me into that thing, right? I wasn't going to do it. Doesn't make me a PDA. It just means that I wanted to assert some of my own control over my life and my body. Okay, so the internal demands, this is where it gets a little bit different for PDAers. Internal demands are the body signals that our organs send to us that we have to do something. So our bladder will send us a signal that we need to pee, or our stomach will send us these gurgles and these cramps that tell us that we need to eat. Or we will quite literally throughout our entire body start feeling that need to go to sleep. These are sort of the internal biological signals that our bodies will send to us. What makes a PDA different from somebody who's just experiencing sort of normal amounts, and that varies, of course, of demand avoidance, is that PDAs are very often extremely activated by these internal demands. I see my PDA kids, like, they will be doing the pee-pee dance, and it's very clear that they need to go to the bathroom, but they will hold it and refuse to listen to that signal, even though it's clear that they hear it, because that demand is not wanted. That demand was not something that they asked for. It was something that is happening out of their control, often interrupting something that they're doing. And it feels in some way like a violation of their autonomy for this body signal to come in and say, you need to do this now. That is very different, I think, than what a lot of other non-PDAers experience. I might be annoyed if I'm in the middle of writing something really good. I got a really good flow going. If I have to pee, I might be annoyed, but it's not going to throw me into nervous system activation or a meltdown because I have to get up and pee. I'll just be like, how annoying. And I'll get up, I'll go do it, and then I'll come back. Then we have self-imposed demands, and a lot of families of PDA kids can really relate to this example. Self-imposed demands are demands that the PDA puts upon themselves. This is an example that I hear over and over and over again from families. The kid gets invited to a birthday party. It might be 2 weeks before the party. They say, yes, I want to go to this party. They might be very, very, very excited about the party, asking many times every day, how many days into the party? When is the party again? Can you tell me about the party? All of that up to the event. And then when it's the day of the party, they say, I'm not going. I can't go. I will not go. Almost clawing to get out of doing the thing that they've been excited about for 2 weeks doing. This is like a really common example of what a self-imposed demand and the subsequent demand avoidance looks like for a PDA. I also don't experience this. I usually, if I want to do something and it was my decision to do it, I'm usually quite excited about this. So there are certain things that I relate to with PDA kids, and then there's certain things that I don't, which lets me know that I'm probably not a PDA-er, but I do have some of those overlapping characteristics, probably because I have ADHD. So a lot of that stuff I can relate to. For you guys who are parents of either a kid or even, whether or not they're still a kid or if they're an adult, do you see any of these internal and self-imposed demands popping up for you in your parenting? I'm seeing some nods. Now, this stuff can be really tricky, especially if you have a non-speaker. It is very difficult to know if they are experiencing these things. That can be really, really tricky. If the individual can't describe it out loud, or if they can't have a back and forth dialogue about what's going on, it can be really hard to spot. But there certainly are PDAs who are non-speaking. And there are ways that we can figure that out. And we'll kind of get into that at the end here. Okay. I talked a little bit about nervous system activation, so I'm going to talk a little bit about what I mean when I say that. We have a survival instinct, which we often call the 4 Fs. And this is like sort of our nervous system's job to protect us, where when we are posed with a threat to our survival, our systems will go into one of these 4 Fs. They are fight, flight, freeze, and fawn. Most people are familiar with the fight and the flight and not as familiar with freeze or fawn. PDAers often are experiencing a much higher level of nervous system activation and are going into one of these 4 Fs much more frequently, usually for longer durations and with much more minimal stimulus than most of us would for this. So an example of that most people can kind of relate to of how this looks for just any old person, non-PDA. This is an example I use very often is if you're sitting at your desk and you're working and maybe you think nobody else is in the house and you're working, you're kind of in a flow state, not really paying attention to what's going on, around you. And if your spouse suddenly walks up behind you and puts their hand on your shoulder, you are very likely going to startle. And your nervous system is going to go into one of these 4 Fs. most people are going to do either the fight or the flight, right? They're going to either like pull away really quickly from that hand and turn to see who it is. And you might put your hands up to shield yourself. Or, I don't know, if you're somebody who's more prone to fight, you might turn around and throw a punch or something, right? In some way, your survival instinct is going to take over and you're going to go into defensive mode until you realize, oh my gosh, it's just my husband. And then you're going to say, oh my gosh, babe, I had no idea you were even home. You scared the crap out of me, right? But that is just like an everyday example of how these 4Fs are built into our nervous system to protect us. But like I said, our PDAers, they're hitting these 4Fs much more easily, much more frequently. The flight often looks like elopement. It can look like running away, an extreme need to get away and physically avoid a situation. And we see this a lot in PDA kids. The fight can be physical, literal physical fighting, throwing fists, kicking, biting, all of that, or it can be verbal. There can be verbal fight where you're screaming at somebody, shut up, I hate you, you don't know anything, you're not the boss of me. All that stuff can also fall into the category of fight. Freeze sounds pretty much like exactly what it sounds like. It is often the individual quite literally freezing, often losing access to spoken language if they have spoken language, and completely going into a freeze mode. You often will see that they're not even blinking. We're in this state. It is a state of being very, very startled and not being able to access really their thinking brain or the skills that they have until they come out of that state. And then fawn is probably the hardest one to spot of the 4Fs. Fawning is what a lot of PDA kids will do at school. So with a lot of PDA kids, something that we're going to hear from school is they're completely fine at school. They're like a model student. They're a role model in our classroom. We have absolutely no problems with this student at school. But then the child comes home and has a complete meltdown every single day after school. Very common scenario for PDA kids that are high masking, so low support needs, and very, very good at kind of quote unquote fitting in and masking to look like the rest of the kids. Their systems are fighting incredibly hard to fawn and look like they're social and happy and not autistic at all. And that, of course, takes a huge toll. And usually the fallout is extreme emotional dysregulation after they get out of that school environment. Usually this is happening because that environment is not viewed as being completely safe and the individual doesn't feel that they can really be themselves. So they are in this fawn state, which is actually taking quite a lot of their energy until they can finally take off that mask, and then they usually fall apart. And I hear this from a lot of the families of young PDAers that I work with. So just a little bit there about the nervous system. And then to, further complicate it, all of these things can be either internalized or externalized. And of course, if you have a kid who's quite internalized, it can be really, really hard to spot, and it can be even harder to help them if you're not entirely sure what's going on internally. With that fawn response, that's exactly what it is. It's really internalizing that nervous system response. So people really are quite bad at recognizing it, especially in the schools. If you don't know what a kid looks like in multiple environments, it can sometimes be very confusing, and they won't notice that this child is quite dysregulated because they're looking so together and so calm and so social and all of that. Externalized nervous system activation is obviously more easy to identify because it's much more of that fight and flight reaction, yelling, stomping, and hiding, and we can see it and we can observe it, and so that we can describe it. Internalized nervous system activation can be really subtle and hard to recognize, and I think that it puts these kids at a much bigger risk because of that, to be honest. And PDAers can be internalized in one environment and externalized in another. Exactly the same thing with the example I just gave of the kid who's fine at school and then falls apart as soon as they get home. They're internalized in one environment, externalized in another. And that usually has a lot to do with how safe they feel in the environment and with the individuals that are in that environment. And these things are all quite unconscious. And kids and teens will do these without even doing these things without even realizing that they are doing it. So it's not really a voluntary act by any means. Okay, equalizing behaviors is another core characteristic of the PDA. Equalizing behaviors can be described as behaviors that follow a perceived loss of autonomy or a power imbalance. So I'll give some examples because I always think that it's good to have some examples. I had a PDA kid who that's a long example. I'll give it anyway. I had a PDA kid who was going to be pausing services with me for a period of time because they were going out of town for an extended period. They were going to go spend the summer in another state and they weren't going to be seeing me for a while. And I wanted to make sure that I just briefly touched on it with this client before their last session before the summer. So I let this client know, just stated it out loud with no expectation from them to respond to me in any way. And I said, hey, just wanted to make sure you knew that this is going to be our last session for a few months. And then you're going away for the summer and I'll see you when you get back. And I'm going to really miss you. I was delivering information to this client that they had no control over. They also really enjoy spending time with me because I am one of their safe people and I provide a safe environment for them. I provide a lot of nervous system regulation supports for this client. So I think in that moment, just simply telling them that there was going to be a change to our routine tipped the scales in the power balance in our relationship. And I often think about this like a seesaw, right? I will like visualize the seesaw in my mind. Just me telling them that information tipped the seesaw. Equalizing behaviors happen in order to restore that balance. So what happened next is that this client asked me to push them on the swing. And so I did. And we were just silent during this time. I was just pushing them on the swing. And quote unquote, out of nowhere, but I know it wasn't really out of nowhere, the client jumped off the swing and said to me, you're not pushing me high enough and I'm leaving. And then they left to go back to their parents' car. You know, was I actually not pushing them high enough or not doing it right? Probably not. But this is a way of restoring the balance in the situation of what just happened. It's important to recognize and understand this because I'm going to respond to it very differently when I recognize what this is. It's equalizing behavior. So what I said to them is, I said, you're right. I'm really sorry about that. I'll follow you from a safe distance so we can make your way back to the car. And I let him leave and I let him be mad at me because that's what needed to happen in that moment to restore the power in our relationship. I understood what this was, the purpose it served, that he really had very little control over it, and that I had shifted the power and he needed to shift it back. So again, really important to recognize these equalizing behaviors for the purpose they serve, which is to restore the power balance, the autonomy, control, and equity in a relationship. These things are very likely rooted in anxiety, and very likely the child or teen doesn't really have that much control over it. So we, very much I guess, recognizing that and then coming at it from a place of empathy, I think is incredibly important. Any questions or thoughts really quick before we dive into PDA versus whole body apraxia? Because I think this is going to probably curtail our conversation a little bit. Okay, feel free to jump in if there's anything else you guys have thoughts about there. Okay, I thought it would be very important here to include some information about what PDA is versus what whole body apraxia is, because they can look very similar. They can also occur in one person. You can have somebody who has whole body apraxia and is also a PDA, or it can just be one or the other. And knowing the difference can be important because I think the approach is different of how we would approach a PDA only child versus a whole body apraxia child. So as you see, these first couple bullet points are exactly the same, right? For PDA and whole body apraxia, more likely to occur in autistic individuals for both. May be observed as difficulty complying with demands, especially external demands for both, right? Both of those things are true. May demonstrate increased dysregulation compared to non-disabled peers. True for both, absolutely. Definitely hitting more of those 4 Fs than your non-PDA or your non-apraxic individual. This is where things kind of shift and we start seeing that there is an underlying difference. For PDAers, suspected underlying cause is likely anxiety and nervous system reactivity, very sensitive, highly sensitive nervous system reactivity. Whereas for apraxia, the suspected underlying cause is that brain-body disconnect caused by apraxia. Different underlying reason for why we're seeing what we're seeing on the surface. The needs are also what differ here. The approach can be very different, whether it's PDA or whole body apraxia. For PDAers, we're going to get into a lot of the accommodations and approaches and interventions for PDA kids, but just sort of simply, their needs are for autonomy, control, and equity in relationships. Whereas in whole body apraxia, the need can be some of those things too, but also motor coaching support and interventions that are specific to apraxia and dyspraxic individuals. Go ahead, Carl.
You've mentioned a couple of examples of your work with younger children.
Mhm.
This question is specifically about PDA, not about apraxia. Do you find that PDA comes and goes with different stages of development where there may be big changes happening and uncertainties, for example, puberty, or when you move a house across the country or
Hmm.
change schools from middle school to high school, these kinds of transitions?
I PDA is definitely a spectrum, with some folks experiencing a milder form of these characteristics than others. But I don't see ever any of my PDA clients, and I've followed kids for years and years and years, never look non-PDA. They're always PDA, but when well accommodated, they certainly can have fewer meltdowns, fewer externalized behaviors, because PDAers can go into extreme burnout where they no longer will eat or take care of basic human hygiene, sleep, things very serious, challenging things will happen when a PDAer is very unaccommodated. But even when it's super well accommodated in the best possible school environment, everything is stable at home and all of that, they are still very much a PDAer. But yes, I would see like an uptick in PDA characteristics during some of these major transitions, but never going from PDA to non-PDA.
All
Does that
right.
make sense?
It does, yeah. I mean, it's sort of well, it's very helpful to know.
Okay. I mean, if you want to get into a case example, I
No,
welcome
no,
it.
I'm just thinking that um, sometimes it's nice to know there might be a light at the end of the tunnel, but that's not what I'm hearing from you.
Well, there are very successful and thriving PDAers, and I am friends with
Yes.
quite a few of them. So, I also, I don't think I put this in this presentation, but I have a kids coloring book on PDA for PDA kids to learn about what PDA is. And in that coloring book, I just kid friendly language about what PDA is and what helps PDAers and all that good stuff. And at the end, I talk about what PDAers are really good at, because PDAers make incredible leaders. They are really creative problem solvers, creative thinkers, often have a very strong sense of justice and ethics, and really often become some of the most amazing people in industries where innovation is really important. And so a well accommodated PDAer can truly thrive and become exactly who they want to be in this world. So to me, that is very much a light at the end of the tunnel, right? It is hard when you're raising a young PDAer. Like there's no two ways about that. I mean, most of my caregiver coaching is to caregivers who are raising a PDAer because is extremely hard. It is. I don't want to sugarcoat that it really, really hard on the caregivers.
Yeah.
But with the right tools and the right support, and I really don't think any parent should be raising a child without support, but PDA parents in particular do need, I think, quite a village of support. And I think PDA kids and teens especially really need several safe adults outside of their immediate caregivers that they can go to, that they can talk to, that they feel safe conversing with and talking about the issues in their life. So I mean, gosh, if you don't have a community around you already, I really would say start building that, because that's probably the
Mhm.
most important thing for caregivers to have support and the accommodations they need to do their job as a caregiver of a PDA.
Yep. Thanks.
Yeah. Yes, Gail.
So, thanks, Jess. So my question would be, one never, it's a life condition to be a PDA. There's
As far
no
as we know, we don't
cure.
know that for certain because the research isn't super clear on that.
Okay.
But it does seem to be something that these kids are often, they are born this way. Parents will describe their babies as having certain characteristics that they knew something was up here, and then it sort of continued. Figuring out the best way to accommodate and help that individual thrive is really the best way forward. But I mean, yeah, all of the PDA adults that I know, they haven't grown out of it. I've not ever
So,
heard anyone say that they've grown out of this profile.
so I can see it in my son, who's 39. But now I'm thinking, is it because it's just a behavior that has been so established because we didn't know any of these thoughts, concepts, 20, 30 years ago. So is it just that it's behavior that's so rooted in him that it is the way he is, or is it a continuous that the PDA? And I see that freeze in him all the time. I just saw it this morning again, and I'm now going, oh yeah, there's the freeze. And so is so is there any improvement? Like in speech therapy can help their speech, right? But is there any
I love to
continuous
talk about
behavior?
what the speech therapist can do for PDAers because I think there's quite a lot, but
Yeah,
not just speech. I
but
almost never work on speech.
the how do you treat them to get over their anxiety? You acknowledge their anxiety so that they um don't just freeze at everything, that they then respond and carry on.
Well, the good news is that it's never too late to help an individual learn about their nervous system and how to accommodate their nervous system and their anxiety. You're never too late for that. And if, the PDA adult friends that I have are mostly in their 30s and 40s and beyond. And of course, they didn't really have these accommodations when they were young either. But as adults, they're beginning to learn about themselves and how they are, their wiring, their systems, how these things show up for themselves. And they're finding therapeutic approaches that are helpful for them. And I can anecdotally talk a little bit about that at the end and some of the approaches that are currently being studied. I can even talk about my own personal experience as well. So if I don't remember to touch on that at the end, please remind me because I will. I'm going to talk really quickly through, I think I just have a few more slides here, and I'll talk about some of the approaches and accommodations that are really helpful really at any age. I mean, some of these are kid specific, but a lot of these, you can modify for any age individual who's experiencing a lot of dysregulation, highly sensitive nervous system, all of that. If you don't already know what declarative language is, definitely Google it. This is one of the most easy changes to make, and it's so helpful. Declarative language is language that we use that doesn't demand any particular response from the person that we are speaking to. So making statements, making descriptions, using think alouds, and figuring out how to change your language to make it more declarative instead of imperative, which demands a response, is such an easy switch to make. And once you start talking like this, you kind of do it forever and you never stop doing it. It's like riding a bike. You learn to do it and then you're like, oh, I always talk like this now. And I never ask anybody questions really anymore. So an example of this might be like, this is a pretty simple and silly example, but a demand or an imperative you might say to a child is put on your shoes. It is language that demands some sort of response from the individual. And a way to swap that declaratively might be like, we're going to go outside. I wonder if we should put shoes on. It's sort of like a wondering aloud, putting it out there that you're thinking about this, but you're not directly demanding that the child stop what they're doing and go respond and do what you ask them right away. So it allows more autonomy and freedom and personal choice in the matter. And again, that's a very simple example, but as you start doing some research on this, you'll see there are a lot of ways to change your language and make it more declarative. And it just allows for a lot more autonomy. In therapy, play-based, child-led, interest-based therapy sessions is incredibly valuable. If you have a child, teen, adult that is in therapy, and your therapist can be creative and flexible in thinking about how to make things more individual and individual-led as well, that is incredibly accommodating. Social coaching and think alouds, that's something that I do quite a lot in my therapy. Like I said, I don't work on speech all that much. I do a bit, but a lot of what I do falls more into the category of pragmatic language interventions, which is more like social communication. And I do a lot of this with my PDAers. Empowering the PDAer by placing them in a leadership role or putting them in the role of the teacher is also incredibly powerful. I had a whole session last week where a child taught me how to skip rocks because they were the expert in the area of skipping rocks and I knew nothing about it. Spoiler alert, I did not learn how to skip rocks. I still can't. But he got to be the teacher. He had a lot of power in our session, which was incredibly accommodating to his nervous system. And he left really regulated and very happy because he was able to teach an adult how to do something they didn't know how to do and they failed at it. And so that was like really, really powerful for this PDA. Strewing, which is a terminology that really just means modeling without expectation or putting out offerings of things without the expectation that the child needs to do it, allowing them to come to it in their own time and space is another accommodation very often talked about for PDA kids. And when it comes to individuals who very often go into this freeze response, a lot of times what I see overlaps with PDA clients is what we sometimes refer to as selective mutism or losing access to spoken language if they have spoken language. One of the things I do for a lot of my PDAers who are prone to freeze or losing access to language or having situational mutism is getting them an AAC device, either a phone or a tablet or any kind of speech generating device that allows them to communicate without using mouth words. This is another area where SLPs can be really, really helpful if they have an understanding of PDA and the need to have alternative modes of communication. Learning about co-regulation, learning how to spot those subtle signs of dysregulation before it turns into something bigger, signaling safety through a relaxed posture, facial expression, and tone of voice is so important. I have like a whole post just about this, about getting down on the level of the child and how reassuring that is from a safety perspective. When we are adults standing and looming over kids, just that, standing up tall and they're only about this high to us, just that can be such a nervous system trigger. It feels so threatening and so unsafe. So something so simple we can do is just drop down to their level, talk to them at their level. That is like quite literally like making you equals, right? Like physically equal is just such an easy accommodation we can make with little kids in particular. Whenever possible, shifting and reducing demands in response to changes in their capacity, right? So like, for example, if usually they're able to shower every day because they have full capacity, but then they're starting to lose a lot of their capacity to do something. If you as the parent or the caregiver can start reducing that demand by saying, you know what, I think a shower every 3 days is actually totally fine. That's one way to accommodate. So Carl, going to your example, if you have a child who's like starting at a new school, they've just moved into a new house, there's like a lot of changes going on, making some of these easy accommodations to what actually drains their battery and their capacity to do the daily things. If we can reduce that in some way, that is really helpful and really accommodating. Just because the child, quote unquote, can do it when they're at their best doesn't mean they can do it and access that when they're lower capacity. So usually they put on their shoes, but right now they're low energy and they're low capacity, and we're just going to do it for them. They're not going to lose that skill. It is truly accommodating and helpful when an individual is lower capacity. And then I always like to just quickly touch on boundary setting because we talk a lot about giving more freedom, more power, more autonomy to PDA kids, but that does not mean that they can do whatever they want and we don't ever set boundaries because, of course, kids are still kids and they do not have a fully functioning and developed frontal lobe, which is where we have our executive functioning skills like critical thinking, problem solving, sequencing events in order to complete a task and organization. All that happens in the frontal lobe, and kids don't have that developed until they're in about their mid-20s. So we still obviously need to set some boundaries and put some things into place so that they know what is safe and unsafe to do. And a lot of times I'm going to really keep my boundaries mostly around health and safety as much as possible because too many boundaries is often not helpful when it comes to a PDA kid. So I like to make sure that they're actually quite reasonable and really need to be there for safe and healthy health purposes. And it's important for us to model that because we want kids to grow up to be adults who understand how to set boundaries with other people, with their boss, with their partner, with their friends, with whoever it is, because boundaries are really important. I think I might have my boundary recipe in here somewhere. Yeah, here's my boundary recipe. This is what I like to do with my own children, with my clients, with everybody, right? If I'm going to set a boundary, I clearly communicate what the boundary is using very specific language. I provide the why behind the boundary, and it has to be a real why. It can't be like, because I said so, because I'm the adult. That's not a real why. And a PDA is going to see right through that, right? It has to have a real reason behind it that makes sense, that is logical. And then whenever possible, I'm going to offer some sort of alternative, or I'm going to change my own behavior in response to my setting of that boundary, because they might not change theirs. And I can't control other people. I can only control myself. I think that I have an example in here. So this is something that like quite literally happened one time. You know, a kid was throwing dirt and they're having a lot of fun throwing this dirt, but it started like actually hitting me in the face. And that really didn't feel good to me, and it didn't feel safe to me. And so I let them know that, you know, I don't like dust and dirt being thrown at me. I told them why the dust and the dirt is hurting my eyes and my throat when it's getting thrown in my face. And I said, if you want, we could throw some leaves. I think that, you know, that wouldn't bother me too much. And then I told them, I'm just going to move a bit back further here so the dirt's not hitting my face. So they could have continued to throw the dirt, and I would have then been out of the way of the dirt. But this child did want to interact with me. So they modified. They threw dirt for a little bit longer because that was the equalizing, right? I set a boundary, and so some equalizing was going to happen in response to that. But I was then at a safe distance where the dirt was no longer, you know, going into my eyes. And then after a couple of minutes, they went, okay, let's do something else. And they moved on, right? So, you know, boundary setting doesn't have to be super scary. And I do think it is quite important for all kids, but specifically for PDAers who can be quite compliant sometimes, especially female presenting PDAers can be overly compliant and can quickly go into that fawn state. And that does make me worried about their safety later on if they don't know how to set boundaries with others. Boundary setting is a form of self-advocacy. And this is my favorite Ross Greene quote that I always keep very squarely in my mind when working with kids and with my own kids, which is that kids do well if they can. And if a child's not doing well, that means that we need to support them, and we need to help them to develop new tools and new strategies. If they had it, they would do it, right? And another quote from a friend of mine, an SLP down here by me named Janelle, she said to me one time, and I never forgot it. She said, no kid wakes up and says, you know what? I want to have a really bad day today, right? Kids, they don't do that. They're not trying to make our lives hard. They don't want to have a bad time. They don't want to have 6 meltdowns in a day. That's hard and horrible and exhausting, right? If they could not do that, they would not do that. So if they are doing it, that is a clue to us that they need more help. They need more support. And as adults, it is our job to figure that out and help them find their way. So here is my final quote from my friend Lucas Harris, who is an adult PDA. Being able to say no and knowing that my no will be respected sets up a foundational feeling of safety. Trying to push me past a no is the quickest way to trigger a fight, flight, freeze, fawn reaction. My no can change to a yes given processing time, but it's much harder to do that when my amygdala is super activated. Read nearly impossible. And I have a mature prefrontal cortex to help me out with that. Kids, teens, and young adults don't. Find providers who see how awesome, strong, and resilient your kids are, and that don't blame you for your kids' behavior, especially for kids that have a strong fawn response. We are not broken. Focus on supporting us and not fixing us. And then at the very end of this presentation, and then we will definitely have some questions, even though I know it's 4 o'clock. Here is my info, my email, my Instagram. I'm very active on my Instagram, and then my website. And then I have my QR code for Venmo if you would like to make a donation. And then I have a lot of references at the end. I'm going to share this the slides with Gail so she can send them out to anybody who wants them. If you want to be able to see, go back and reference these slides, and then also the references here at the end. And then some additional resources, folks on social media who talk a lot about PDA, and then some good websites here as well. And that brings us to the end. And then Gail, if you think it's okay for us to go a little over 4, since we started a little late, in case anybody has questions, we can do that.